for inviting me to come and speak this evening. It's kind of the new age of virtual meetings, isn't it? But I think actually they probably have their strengths, to be honest. I was going to mention that a little bit actually at the end. So I was going to focus this evening on autoimmune hepatitis, and as John mentioned, LIVErNORTH have very kindly been sponsoring, I mean, they've supported us with a number of projects, but specifically UK AIH been funding us for the last couple of years now. So I was going to talk about some learning from UK AIH and also a couple of other projects we've done recently, again, which LIVErNORTH have been involved in. And as John mentioned, I do work at the Freeman as a hepatologist, but also now run a liver outreach service at Sunderland Hospital. I have done since June 2018. So we're trying to kind of take some specialist services to different hospitals around the region. And some of you will be aware of this because I have some of my Newcastle patients I now see in Sunderland. So actually it's geographically much better for them than having to travel through to Newcastle to see me. So I'll make a start. And I know not everybody on the call, people are affected by different liver diseases. So just a brief overview of autoimmune hepatitis. So it's a rare disease, as are all the immune system liver diseases. It affects about 17 per 100,000 in the population. And it's an inflammatory disease, so it causes inflammation in the cells within the liver. That's in contrast to PBC or PSC, so they're both bile duct diseases, so they're slightly different. Autoimmune hepatitis is mostly females, at about 80%, and people present in lots of different ways. Probably the commonest actually is people go to the GP either for a blood test for an entirely different reason or because they were just feeling a bit off colour and they're found to have abnormal liver blood tests. Some people present jaundice, so they present, yellowing of the eyes, and very occasionally people can have kind of extreme aggressive autoimmune hepatitis that's causing failure of the liver, needing transplantation, but fortunately that's very rare. And people have symptoms both from the disease itself and also the treatments we use, and that's one of the things we'll be focusing on this evening. Symptoms, as with all our autoimmune liver diseases, can be fairly variable, ranging from fatigue to itch that we see particularly in PBC, generally not feeling right, and some people have some abdominal discomfort up in the right upper side of the belly where the liver is, but often not very many symptoms at all. So NIHR is one of the big research funding bodies in this country, and UKH was set up a number of years ago now, in 2014, and NIHR originally funded the cohort, and then, as I say, more recently over the last few years, LIVErNORTH have taken over that funding for us. And it was set up really as there's an opportunity to develop a really large group of patients with a quite rare disease by collaboration between the NHS and the research funding bodies. And really, I think it's one of the demonstrations of the importance and success of collaboration. UKH has 56 sites across the country, and we now actually have 2,500 patients participating in UKH. And I think it has really given us the opportunity to learn about this rare disease and try and move things forwards for patients. It is a national study and it's open to all adult patients as it stands, with a clinical diagnosis of autoimmune hepatitis. And it was set up for us to really understand the unmet need in this disease and to provide a platform, a way of getting better to establish if we need better treatments, and if so, move towards getting them. And certainly we have newly diagnosed patients, so we ask patients if we think they are about to be diagnosed with autoimmune hepatitis, they are participate in the study and then get followed throughout their progress. And also anybody who's already got a diagnosis can take part. And just broadly, an overview of treatment of autoimmune hepatitis. So if you come to my clinic, I've got a fairly simplistic way of thinking about things in some way. So my feeling is we get control and then we keep control. And the way of getting control of inflammation in the liver, broadly speaking, we use prednisolone. So prednisolone is a steroid. it acts on the whole body. It's not targeted at a specific part of the body, and it's not targeted towards the liver specifically. But most people will get prednisolone, and there are a small number who get given budesonide. Budesonide is also a steroid, but it's a steroid that is focused, it acts on the liver specifically and doesn't have the rest of the body effects. The reason we use prednisolone is that all the original trials, the drug trials that were done that showed evidence of benefit for patients with autoimmune hepatitis were with prednisolone and azathioprine. Until relatively recently, budesonide is a relatively new drug, and there are some trials, but we're really finding our way through where it fits in the various treatments we've got. But there are some patients for whom it's probably appropriate. And once we've got on top of the inflammation, then we need to keep on top of it. And there are a variety of drugs. Some of these will be familiar to people in the audience. Azathioprine is the one we tend to use, or certainly in my clinic, we tend to use first line. There are some others, so 6-mercaptopurine, mycophenolate mofetil, and tacrolimus. But the majority of patients would start on azathioprine. And what we do is we start with a high dose of steroids, gradually reduce that dose of steroids, and increase add in azathioprine or one of the other drugs. And that allows us to have a very low dose of steroids and ideally stop the steroids. And if we think about goals of treatment, well, of course, we want to get good control of the disease. And by that, we need regular monitoring. We're aiming for normal liver blood tests, and we're also aiming for a normal IgG. So this is another blood test, and it's a protein that's produced by the immune system. And those two things are markers of disease activity in autoimmune hepatitis. I've put liver biopsy on here because anyone who's got autoimmune hepatitis or knows somebody with autoimmune hepatitis will know that the majority of patients have a liver biopsy to diagnose autoimmune hepatitis, unlike in PBC where most people don't get a liver biopsy. We use biopsy for diagnosis, but also we do sometimes use biopsy throughout somebody's disease course. Sometimes I would suggest a biopsy before I think about stopping treatment. Sometimes I do a liver biopsy if I want to work out exactly what's going on as an up-to-date assessment. And we're aiming for treatment with one immune suppressing drug. So often that's azathioprine just by itself. That isn't always possible. Some people need some azathioprine and a little bit of steroid. But generally speaking, we would try to avoid long-term steroids if we can. And of course, we want to stop the disease getting worse. We want to protect people from running into problems with an increased scarring in their liver and getting worse over time. And of course, we also want to improve quality of life. We want to enable you to do all the things that somebody with autoimmune hepatitis does and not have it impact on your day-to-day life. So UKH, as I say, we were set up to address the unmet need, to establish whether we need better treatments, we need good treatments with less side effects, and also to address, well, to quantify and then address the issues regarding quality of life for this patient group. And having spoken, I mean, obviously, for those who don't know you, I look after the clinical autoimmune service in Newcastle, which is quite a big clinic. And having spoken to and looked after a lot of patients, I think, broadly speaking, I think there are three groups of patients that we think about in terms of treatment. There are quite a lot of patients who have good control of their disease, they don't get any side effects, and actually, we don't need to change anything. We should just leave things exactly as they are and carry on. There are, fortunately, a relatively small group of patients who we struggle to get their autoimmune hepatitis under control despite the currently available therapies. And then I think possibly actually the largest group is I can get the autoimmune hepatitis side of things under control, but some of the treatments come with quite significant side effects. And I think there are differences in what each person as an individual feels is an acceptable side effect in order to gain disease control. Generally speaking, the message that we get is that there's a high premium placed on being steroid free, so being free of prednisolone or budesonide. And I suppose part of the question is what dose is okay? Is 5 milligrams of prednisolone okay? And goal one, I would say, what I would hope for us to have is a range of treatment options so we can use different combinations, different treatments for different people based on the individual's needs. And we also want to get better disease control whilst moving away from use of steroids. And this data is from UK AIH. So this was the first paper we published in 2018 now, and it was looking at the first 1,249 patients who kindly took part in the study. And this is just, so about, I don't know whether you can see my pointer, but about 50%, it's about 50-50 split in terms of patients who were cared for in transplant units. There are 7 transplant units in the UK. And obviously the vast majority of hospitals are not transplant units, but this was 50-50 pretty much between transplant and non-transplant centres. And we mentioned at the beginning that about 80% of patients with autoimmune hepatitis are female, and that is what we see in autoimmune UK AIH. And there were some key findings in this paper. So 59% of people had normal blood tests, so they had good disease control. Actually, the drugs they're getting are working just fine. There was a lot of combinations of treatment. So there are actually 29 different combinations of treatment that people were across the UK were receiving. Now, if you think back to that slide when I listed the treatments, there were nowhere near 29 drugs. So there's all sorts of kind of combinations and slightly unusual medications being used. We've talked about the idea of trying to get people off steroids if we can, but actually over half, 55% of patients are on long-term steroids, and actually 10%, so 1 in 10 people are on steroids alone and aren't on any other immune suppression. And I think it's important for us to remember that about 1/4 of people have cirrhosis at the time they're diagnosed with autoimmune hepatitis. And that does suggest that there may be a delay in diagnosis of some patients. And I think that's probably a demonstration of actually people often don't have many symptoms. So if you don't feel unwell, why would you go to the doctor and why would you get a blood test? I think it's also important to say, quite a number of the people I've looked after, even if you have cirrhosis at the time you were diagnosed, some of you will know from personal experience that with good treatment, some of that scarring in the liver can actually improve again. So we can reverse some of the damage to the liver with good treatment. And this is the second paper we published. So this is a slightly funny title to that slide, but there were 990 patients in this study. And this was all looking at quality of life and the effect of autoimmune hepatitis and the treatments we use on quality of life. And this is the largest study that's ever been done looking at quality of life. And we did demonstrate that on average, so not for everybody, but on average, quality of life was poorer for patients with autoimmune hepatitis than in the general population. And primary biliary cholangitis, which I touched on earlier, and many of you will be familiar with, we know that patients with PBC, it's well recognised that there's significant symptoms, again, for some patients, so tiredness, itch being classic in PBC. We don't see itch really at all in autoimmune hepatitis, but I think it's important to see that actually there are quality of life problems with autoimmune hepatitis and PBC, and I think it's under-recognised in autoimmune hepatitis. People's quality of life is better if they have well-controlled disease. Quality of life is worse if you're taking steroids, generally speaking. And actually, people have more fatigue and more significant symptoms if their disease is poorly controlled or they're on steroids. And I think that raises some interesting questions. We need to think about, is it the disease that's making people feel unwell, or is it the treatments we're using? So that's some of the UK AIH data, and I'm just going to move on to a couple of more recent, well, not more recent, but ongoing projects that we've done recently. And so we undertook a patient survey just about a year ago now. It was designed by a combination of doctors and patients, because clearly if we didn't involve patients in the survey design, we wouldn't know the important questions to ask. I need to mention Linley Wong and Jess Layton here. Linley, some of you will know, she was our fellow in Newcastle. She's a research fellow, sorry, and she's now working in Exeter as a consultant. And Jess Layton, so she's been with us on and off for a few years now, first as a medical student, and now more recently, she's a junior doctor in Newcastle and is an academic trainee with us. And we had patient representatives from LIVErNORTH were closely involved with this, and AIH support. And we developed the patient survey and then used an electronic link, and also it was available on the UK AIH website. And in terms of raising awareness and advertising the survey, again, LIVErNORTH were key to this, AIH support, one of the other national support groups, and the British Liver Trust. And we received 270 responses, kind of average age was 55 years. And interestingly, the vast majority of respondents were female. So although we know that only 80% of patients with autoimmune hepatitis are female, we actually had a much higher proportion when we did the survey. And I was reassured, we asked various questions, got people to rate various questions, but actually I was quite reassured that when we asked, do you feel if your autoimmune hepatitis is under control, that actually the vast majority of people said, yes, definitely, or yes, probably. And I think that that's really important, that people feel like their disease is well controlled and they can be confident in that. However, we also then explored medications and side effects, and actually 66, so 2/3 of patients had had problems with their medications. And I think one of the things I try to do in my clinic, and maybe I don't always, I'm sure I could do it better, is before I give anybody a treatment, I try to talk to them about the risks, the benefits, so that actually somebody is making an informed decision before taking that medication. But actually, when we asked people, only 2/3 of patients their doctor had talked to them about potential side effects before giving them treatment. And I think that is one thing we really should do better, particularly long-term treatments. They are not without risk, and we should make sure people are aware of those things. And this table on it'll be your right as well, I think. So it's a slightly busy table, but essentially what I've done here was taken out probably the four commonest treatments. So prednisolone, azathioprine, budesonide, and mycophenolate mofetil. And we've just explored a bit more about the side effects people experience. And there are some common themes across them all. So cosmetic side effects, feeling put on weight, skin kind of acne, or insomnia, not sleeping very well, feeling fatigued. GI side effects, by that I mean kind of upset tummy, diarrhea, loose motions, or abdominal discomfort. And you can see that although steroids are one of the things we are aware that steroids cause lots of side effects, actually we're seeing side effects with all the medications to a lesser or greater degree. And this slide here, so we asked patients about various things. These are just 4 of them. So at the top, worrying about the effect of their medications, then worrying about the effect of their disease on their friends and family, worrying about the effect on day-to-day life, and then worrying about the effect autoimmune hepatitis has on them as an individual. And I think that if you look at the top and the bottom bars, the blue bits are all of the time, the orange bits a lot of the time, and the grey bits are some of the time. And you can see that actually across the board, patients worry at least some of the time about all of these things. And I think these things are sometimes we don't necessarily address very well. It's quite easy to, particularly as a doctor in a clinic, to focus on the blood tests, and we're maybe not as good at exploring these aspects of disease. And actually, you can see here that over half of patients either worried about the effect of autoimmune hepatitis has on them, either all or at least a lot of the time. And I think these are things we need to try and address. And this was exploring how people felt about their treatments. So the blue bars are how people feel about being on steroids, and the orange bars are how people feel about their kind of current treatment. Now, we asked people to rate on a scale of 1 to 10. So 1 is really, really unhappy, 10 is really, really happy. And you can see that the orange bars, most people were scoring 7 or 8. So actually, they were pretty comfortable with the treatments they're currently receiving. But actually, when we asked about steroids specifically, the blue bars, you can see that actually there were lots of people scoring 1. And actually, most of the people were kind of further down the lower end of the scores. So actually, they were unhappy with being on steroids. And drug trials. So those of you who have awareness of PBC will know that actually we've had drug trials in primary biliary cholangitis for years now. And, you know, certainly Newcastle is very active. A lot of our patients are, you know, have been, you know, take part in sometimes multiple trials. But autoimmune hepatitis is quite behind the curve in terms of trials being available. And the drug companies haven't really done trials until really in the very recent times. And all of a sudden, drug companies are becoming aware that actually this is a disease that we need to get new therapies for. There is a drug trial open at the moment, and there is another, we're about to open another one in relatively near future in Newcastle. So we wanted to explore, actually, is there a need for trials? Is there a will? Do people want to take part in trials? And actually, 62% of people said they would definitely or probably consider participating in a drug trial. And I think that's important information. And the commonest reasons people wanted or would at least think about taking part were to improve treatment for themselves or others. They believe that research is needed. They want new drugs to reduce side effects, and they want an alternative to steroids. But there were some concerns, entirely reasonable concerns raised about taking part in trials. This concept of I don't want to rock the boat, actually everything is okay, things are ticking along all right, why would you upset it? Which seems is very reasonable. Understandably concerned about the risks. By definition, these are, you know, relatively new medications, relatively new drugs, and also potential impact on their other conditions. And we try to explore support networks. I'm thinking about who's somebody's first point of contact. Who do you go to if you've got a question or a problem? John mentioned Corona. I think it's fair to say that the last year has been challenging at best for everyone, in lots of different ways. But I think anybody in the audience will probably relate to you know, it's thrown up lots of questions. Can I have the vaccine? Should I have the vaccine? Am I at risk? You know, should I be shielding? All of those things. And actually, who did you go to ask those questions? And I suppose that's your first point of contact, isn't it? And interestingly, about nearly half of patients went to their hospital doctor. 37% went to their GP. And actually only 19% of patients had access to a specialist liver nurse. Now, I think that's interesting because I think that's probably an area that is under-resourced. So in September last year, anybody who's in Newcastle will know Kath Houghton, who was still is, but was our lead research nurse, but is now also 50% our clinical autoimmune specialist nurse. And we've partly actually based on some of this work, we've kind of recognized how valuable having that point of contact, that familiar face is. So actually she's joined our autoimmune liver disease team as of September. And I think that as you know, we've had some really positive feedback for that. But I think the really worrying, I think quite shocking thing about both the patient survey and the next thing I'll talk about shortly is that 41% of people were embarrassed to tell people about their condition. They felt stigmatized. They feel that people assume their liver disease is due to alcohol, drugs, sexual transmission. And interestingly, the word hepatitis makes people assume it's infectious. And again, anybody who knows a bit about PBC. So PBC used to be called primary biliary cirrhosis, but actually in 2017, we, as in doctors and patients together, made the decision to change its name to primary biliary cholangitis. It was felt that the cirrhosis part of the title came with lots of kind of assumptions with it. And also the vast majority of patients with PBC do not have cirrhosis. So it was an unhelpful title. And actually, I think the name change has been, and some of you may have thoughts on that, but I think the name change has been very positive and was very heavily backed by patient groups, including LIVErNORTH, to try and support that name change. And we also tried to touch on support groups. Again, about 50% of patients were involved in support groups and found them really helpful sources of emotional support, feeling more understood, having a network of people who actually understood some of the situation they were in, making them feel less alone, and also being really good sources of information. John mentioned the LIVErNORTH booklets, and clearly LIVErNORTH is the group that I have, you know, a lot to do with. And I wrote the PSC one, and I think those booklets are great. I mean, there's more and more and more of them. And certainly, as John says, we now have a board down at Sunderland as well, and the board is you know, gets empty pretty quickly. So I think they're really good sources of info for people, and it saves people just Googling on the internet and finding, you know, information that's not right for them. We asked people what was frustrating, and actually the things that people said were the most frustrating aspects of having autoimmune hepatitis were the fatigue, worrying about the future, and uncertainty surrounding their illness. Now, and that uncertainty actually was not just about what would happen, what's going to happen to me in 5, 10 years, 20 years time. Will I be here to see my children or my grandchildren? Those things, but also the uncertainty around the illness itself. What is autoimmune hepatitis? Why does this happen? What causes it? So all of that uncertainty, and also the impact of medications. And we asked people how we could improve things. What should we do better? And there was a number of things here. So new, better, improved treatments, trying to avoid immune suppression altogether, and certainly avoid steroids, wanting more information, more communication, informed discussion of side effects. We touched on that earlier. You know, only 2/3 of people feel that actually the side effects of their medications were discussed with them, and following a more patient-centered approach. And then this is the last kind of project I wanted to share with you. So Charlotte Lloyd is a medical student. She spent last year with us doing a research project, and I'm very pleased to say was successful in getting her Masters of Research as a result of this. But she's done some really, really interesting work. So she did semi-structured interviews with 13 patients. They are all those patients were from my Newcastle clinic. And really, we wanted to have a much more in-depth exploration of what it is to live with autoimmune hepatitis, and really build on the findings of the patient survey. Inevitably, a survey, I mean, it was quite a long survey, but you still can't delve into the bigger issues. So actually, the interviews were kind of an hour and a half, really kind of pulling apart the things that matter to you as an individual. Again, this all happened during Corona, so credit to Charlotte. They were all meant to be, the intention had been face-to-face interviews, but for obvious reasons that wasn't possible. So all of this was done over the telephone, and all the consenting process was done electronically and by paper and things. So we had to adapt the study to account for Corona. And there were 5 key themes really that Charlotte's pulled from this work. And really the top one, again, really quite concerningly, is the stigma that people feel, believing that, you know, others believing that their liver disease was their own fault, that in some way they brought it on themselves, that they, you know, were drinking too much alcohol, or, you know, doing something in their life that was causing this. And again, the term hepatitis causing misunderstanding with it being infectious. Just to be absolutely clear, autoimmune hepatitis is not infectious. You do not pose any risk to anybody else. And there was no relationship between alcohol causing any of the autoimmune liver diseases, not just autoimmune hepatitis. I think people often, even if they know rationally it's not a problem, actually alcohol does not cause these diseases. So just to be very clear about that. And that stigma then impacts on who people tell, impacts on your available support networks. And sometimes people are trying to kind of actually, when they're telling people about it, say actually it's immune system, trying to emphasize that, but actually struggling with not knowing enough about it themselves to be able to explain it to others. And also, again, what the difficulty that actually none of us know what actually causes autoimmune hepatitis makes that quite difficult to explain to people. And then the second key theme was experience of steroids. Now, I said at the beginning, a lot of people are asymptomatic. Some people just feel a bit rubbish. And actually, when I treat my patients with steroids, that people quite often say, I just didn't realize how awful I felt until I started to feel better. And actually, steroids do give people an initial boost. So actually, you feel better initially quite often. But then the majority of people said actually there were negative effects, both over the short and the longer term. Weight gain is probably the one that people describe most, the kind of facial mooning, facial change, acne, sleep disturbance, low mood, I think and I think we would go as far as to say depression, anxiety, and also the long-term effects on bone strength. There were particular concerns about that and the impact on the long term. And I think probably tying a bit into any form of chronic disease, the feeling of loss of control, feeling loss of control over their own bodies, having to hand control over to their doctor to make things better. And again, the coronavirus was interesting here, I think, and again, people may have comment on this. Some people said, well, actually during coronavirus, you know, we were having to shield because almost all autoimmune hepatitis patients are on immune suppression, so therefore fell into the extremely clinically vulnerable. But I think people found that really, or some people found that very difficult, particularly if they don't really think of themselves as being sick, then being told, actually, you have to be treated differently, you have to shield. It brought out all sorts of different emotions for people. People talked about some quite positive things, trying to take back control, trying to take charge of the things they could. So doing lots of exercise to improve their bone health. We know that weight-bearing exercise, keeping fit, is really good for your bones. Deciding not to drink alcohol, even though it doesn't cause autoimmune hepatitis, but feeling like actually that was something positive they could do. Some people cut out gluten from their diet. And actually they felt more in control by actually engaging with the doctor's decision-making process. There are some people who want to be told, this is what you should do to get better. But actually, I think that's quite an old-fashioned approach in medicine. And certainly we would normally try and have more of a discussion about the options, what are the risks, what are the benefits, so that we can come up with a plan that suits the individual. Talking about what you want and what your priorities are with your doctor, and also becoming more knowledgeable about autoimmune hepatitis, the medications that are used. And of course, things like this, you know, support groups, taking part in these types of things improves your knowledge and also gives you a really important support network. And the other two things, fatigue and patient support groups. Again, fatigue came out as the most reported symptom. And also people describe this feeling that fatigue is not taken seriously as a symptom. And I think that we do see that in the PBC patients as well. I don't mean doctors particularly, but people, the public, maybe don't appreciate how unwell some people feel and the impact it has on them in terms of what they're able to do. Likewise, I do look after lots of people who live very active, very normal lives, do what they want, go where they want. So it's not true of everybody, but for people who do have lots of symptoms, that actually people maybe don't kind of acknowledge how significant they are. And again, support groups, increasing your understanding of autoimmune hepatitis, providing a group of people to share thoughts with. Some people said they struggled to find the time, and when I started right at the beginning, I said, well, actually, this is a virtual meeting. We're all sitting in our respective lounges or studies, and actually maybe I suspect in the same way as all our big conferences have been cancelled, this probably is the way of the future. Hopefully, we'll be able to meet again in person. One can only hope. We seem to all be coming out the other side of Corona, but I suspect the model going forwards might be a mixture of face-to-face meetings and virtual meetings, because actually it makes it much more accessible, doesn't it? If you don't happen to live in Newcastle and you might not want to trog to the Freeman to hear me talking, but actually you can dial in very easily. So I think it does it might be good for enabling people to engage. And there were some people who actually interestingly said, but I don't think of myself as ill, and I don't want to think of myself as ill. I don't want to think about the fact I have a diagnosis. So actually, I don't want to take part in that. And that's absolutely fine. It's different things. Different people want different things. And inevitably, some people find support groups incredibly valuable, and they're not for everybody, and that's fine. So to summarize, I think actually one of the key things I've taken away from all of the work we've done with AIH and then patient survey and Charlotte's work I think one of the things we really need to do is try and address this real stigma that comes with liver disease. We need to educate, I think, the public, the general population, and also us as doctors need to help our patients to understand better and give them the information they need. A lot of people are fine on the treatments they've got. We have good disease control, we have few side effects, but there are people who need better treatments. We need to keep pushing to look for better treatments. We also need to make sure we're using the treatments well. So there are things I can do. If you come to my clinic, I quite often do some tweaking of medications. It's finding the right combination at the right doses for the right person, and it's not just one size fits all. And I think as doctors and traditionally in research, there's been a lot of emphasis put on making the numbers better, controlling the disease, and clearly that is very important. But also, I don't want to make your liver better and make you feel awful. We need to do both, and we need to think about excuse me, we need to do both. We need to, hang on, my key. I need to control your disease well, but I also need to have a real awareness of quality of life, symptom control, and allow you to do all the things that anybody else does. Go on holiday, go to work. I mean, holiday would be a fine thing, but in the future. So those were my kind of take-home messages. Thank you very much. That was all I was going to say, John.
Excellent. Well, thanks very much, Jess. A lot of recurring themes in the talk. We see a lot of liver doctors come and give us talks on all sorts of different liver diseases, and it's amazing how many recurring themes there are, particularly about the stigma attached to it. And we try to make sure that this stigma isn't a problem, but it is, and it's not just the public, of course. Some doctors still are stigmatized by it. You get the old GPs that say you've done this to yourself, even if you've got PBC or whatever. Anyway, I'll stop the recording now, and we'll start Q&A. Now, if you put, wait a minute, find the recording. Where is it? Joan's